Hello, good morning. Yes, hello, how are you? Hey, good morning, guys. How are you? We are first, so good timing. Good timing.
Good timing. How you doing?
This is the Echo Clinic for Pain Management. I am Dr. Michael Lewandowski, pain management psychologist. To my right is Dr. Dennis Patterson, pain management physician. And Paul Snyder is a drug and alcohol abuse counselor. And we represent the pain management Echo team. So it's our opportunity to share with you what we've learned over the years, hopefully with pain management and from all of our different perspectives. And today I've been tasked with the topic, or I've been given the opportunity to talk to you a little bit about pain management from a behavioral psychological standpoint. And one of the ideas I have is to offer you some tools to use. And one of the tools that I found helpful is what I call the pain map. And I'd like to talk to you a little bit about that, how to utilize it, and ideally be able to kind of have some discussion interaction on how that particular tool may be useful on a day-to-day basis with you and your practice, seeing real people with persistent chronic pain. So welcome. I think we have a couple of folks here. Let me, if I could, in the process of getting a little interaction going, ask who is out there. I see someone, there's a Squirts, is it Dr. Squirtsoff? Can you hear me? And okay, and we have Elko.
Can you hear us, Lori? Because we can't hear you.
Yeah, I can see you're taking yourself off.
Audio check. I can hear you just fine, and I'm just a technical guy. So.
Okay, thank you.
Lori, I can see you're taking yourself off mute, but we can't hear you. I'll follow up with you to try and see if we can get the audio issues worked out. For now, if you have any questions, just send them in using the chat function.
Excellent. Okay. Well, we're kind of going to divide this up into two big chunks, if you will. The first one, I'll kind of introduce some of the materials I'd like to share with you, and in the second half, I'd love to turn it open to just discussion and maybe working on some individual cases that we can present. So with that said, let me go ahead and, Troy, if I can get the old PowerPoint up there, that'd be great. Great. So I am Michael Lewandowski, and I've been doing pain management work for the past 34 years. As I mentioned, I'm a psychologist. I have a PhD. I'm actually a graduate from the University of Nevada, and have spent 34 years working with people who unfortunately are dealing with persistent pain problems. So I'm a slow learner, but I eventually get a few things, so hopefully I could share some of those with you today. I'm going to show you the pain map here in just a little bit, but just kind of as an introduction, what I'd love to suggest is that this could be a good starting point or a follow-up point after your medical evaluation with the person you're seeing with who's dealing with pain. And part of the idea, the background here is two things. One, I think every person that I've ever seen who has chronic pain wants to tell their story. They want to feel heard, and they want the doctor to know how they are unique in their pain experience, because they don't know anybody else necessarily who is experiencing the pain like they have. So I think it's important for us to be able to have an opportunity to listen to them. Problem is, I think the latest research suggests that the average physician has about 8.5 minutes to spend with each person. So there's not a lot of time on either end there. So my thought was if I could help develop a tool that maybe allows both the doctor and the patient to kind of get an overview of kind of like a Google map of where they are in their trip down pain lane, so to speak, it would help keep everybody oriented, okay? So, and the other part of that is that I think from the very beginning, and I'd love to get some comments from my colleagues here, that from the very beginning, I would love to reinforce the idea that the patient is not a passive recipient of this pain management care, that they should take an active role. And in part, when I show you a copy of the map, one of the things that I suggest is that you actually hand a copy of this map with a clipboard and a pen to the patient so they can start taking some notes and actually help provide feedback to the medical team as to what their needs are. And I'll get into that in just a little bit. In a sense, I think the goal is to stay out of the way of the patient, but to allow them to tell you, to put their finger on exactly what hurts. And I metaphorically, I mean that as not just the physiology, that's obviously the base that we work from, but also put their finger on those problems that are most pertinent to them, which may actually be behavioral and psychosocial factors, people that are depressed or that they're anxious or they're very angry at having pain. So to have a vehicle to be able to allow them to kind of really fine tune where their concerns are, that was the primary goal in developing kind of this idea of the pain map. So let's see here. So just a real quick background, for those of you who have been through our echo clinics before, this is kind of a review, but my idea, and I think our idea, is that pain is definitely a biopsychosocial experience. It's not just physiology. It has a psychosocial component, and it's important to probably take a look at that. And this slide here is just kind of an overview of that, the idea that indeed there are tissue damage. I mean, that starts the pain problem, but muscle tension, guarding, bracing, all of these issues can also further, from a biological standpoint, perpetuate the pain problem. We'll talk more about depression and mood and pain behaviors, which is a way that an individual kind of conveys to the world that they're hurting. Included in that section there also is the concept of beliefs about pain. Probably the most studied belief about pain is catastrophizing. And we know there's a lot of research that supports the idea that if an individual's catastrophizing about their pain problem, that's going to be a major barrier in their recovery, no matter what the physiology is. And then finally, pain certainly has impact on people. It's not, I say it's not an individual problem, it's a relationship problem, whether that includes relationships with spouses or employers. But pain is not an isolated thing that one person goes through. So we need to take a look at the impact that pain has on others, in addition to one's past learning experience with pain. What you're brought up with. What does mom and dad do when you fell down that first time and skinned your knee? How did they interact with you, and what role does that play in this individual person's expression of pain? So pain is a biopsychosocial perspective. Experience, and we need to take that psychosocial perspective when looking at it. So basic ideas, again, just to review, pain is definitely a subjective experience. We try to objectify it, but it is still at its very basis a personal experience. And once again, we want to try to customize this to understand each individual's personal experience with that, with persistent pain. So no two people have the same pain. I have colleagues that have asked me, how the heck have you spent 34 years dealing with people that have persistent chronic pain? And I say, well, it's kind of exciting because I've never met two people that have the same experience. I don't know if that's your experience too. So it kind of keeps it exciting and fresh to find out what are those unique factors to this particular person that's in front of you that maybe they're the issues that are maintaining their problems. Third point there is neither somatic or psychological models explain all of pain and disability. It's not any one of these pillars, if you will. It's not all psychological, it's not all social, it may not indeed be all biological. And in some individuals, pain is definitely a learned experience, which on an optimistic note means that we can teach people to unlearn some of that. Just as an example of some factors under each of these major headings, inappropriate medications can often perpetuate pain. And part of our clinic here is dealing, and we talked a lot about actually opiate medication use. We've also talked a little bit about how sleep is a huge factor in restoring function and how that can be when it's disturbed, a perpetuator of chronic pain. Physical deconditioning. Many of the people that I see have, basically they learn the more I do, the more I hurt. So I'm not going to do anything. And that leads to just reclining on the couch, which then creates a whole series of other problems that end up perpetuating the pain problem. Add to that, reactions to that. People get tired of laying on the couch, so they say, screw it. And they get up and they go, I'm gonna go mow the lawn and pull all the weeds in the backyard. And they overdo activities and then learn at the end of the day that, oh my God, my pain's killing me, and I probably shouldn't do that again. So this pattern of overdoing or underdoing, which leads to poor activity pacing, a huge factor I would put it under this particular category, if you will. It's certainly behavioral, but it's also biological issues. Psychological factors, probably the biggest thing I see is fear. People are afraid of pain. And when people are afraid of something, they'll do anything to stay away from it. And so we start developing more avoidance behaviors. I don't want to do this because of pain. I don't want to do that. And so from a psychological standpoint, you want to take a look at to what degree are they, is their activity interfered, and how much of that interference is explained by a pattern of not wanting to do things to avoid the exposure to the pain. And from a learning perspective, by avoiding things, it can be highly reinforcing. So it's important to take a look at the level of activity avoidance and fears of pain. Many people also have fears of re-injuring themselves. So if they do something, I don't want to do that because I may re-injure myself and make my problem even worse. Other psychological factors, we talked about past learning, mood issues. I'll talk more about that, and of course, catastrophizing. So that's the psychological piece of this triad, if you will, and the social piece. Others' influence on behaviors. I'm often pleased when a spouse will come in to a session and offer an opportunity for me to see some of the interaction that's going on and the role that plays often in perpetuating someone's pain problem. The classic case, of course, is the very caring spouse who takes over and does everything for their mate because they love them and they don't want to have anything to hurt them. But in the long run, it may end up inadvertently perpetuating inactivity and a continued disuse syndrome. The flip side of that oftentimes is that sometimes spouses get rather upset, pissed off, and aggravated by the pain problem, and then it becomes now a relationship challenge with the person in pain often trying to always prove that they're in pain by increasing their pain behaviors, and then we create a whole different kind of perspective, but nonetheless one that needs to be addressed. In my particular practice, I deal with a lot of folks that have been injured and hurt at work and are on workers' comp. And that is an entirely different world in and of itself, but the whole question about disincentives potentially for getting better. I have colleagues that won't treat anybody with chronic pain if there's a motor vehicle lawsuit going on, in that there may be a secondary gain issue to stay sick because I have to be as bad as I can. And unfortunately, attorneys may inadvertently reinforce this so that they can, when they go to court, they can get the biggest settlement that they feel they deserve because they have been hurt. But here we have, some interesting contingencies that need to be addressed in terms of them being able to get any better. And then I bring up physician behavior and impact on pain. When I did my dissertation, one of the scales that I looked at was how people responded to their physicians. And there was one, of course, the things physicians can do is they can be very kind and understanding and listen to the patient. That usually always led to a positive relationship and the possibility of good outcome. Flipping that coin over, though, sometimes physicians can get frustrated and annoyed and irritated. And the impact that has on certain patients can also be very powerful. So the whole key here is that we have this biopsychosocial model. I would encourage you all to look at every person that comes into your office with chronic persistent pain with that kind of an overall understanding and some of the sub factors there. So thank you for letting me do that. Now here's the pain map. So this is intended to be an interactive process. And in fact, I brought a clipboard with a copy of this. And what I would encourage you to do is to get a pen and a clipboard, hand the patient this actual copy of this map so that they can start the process of moving from a passive role in their recovery to a more active role. And with it, that said, I usually encourage the physician to say, all right, Mrs. Smith, let's write down here under doctor diagnosis inside the center. We kind of start from a center and then move around the outside of this map. So the idea would be that you as the physician would say, okay, here's what my diagnosis is. Mrs. Smith, write down myofascial pain syndrome is just an example. And so they write that in the center, myofascial pain. And ideally, you'd have the time to be able to explain what that is. You know, the muscle tissue oftentimes can, the second greatest organ in our body, correct me if I'm wrong, Dr. Patterson, besides our skin, is muscles. Yeah. So it can be a huge source of comfort and discomfort. So, you describe what you think is contributing to their biological, physical pain problem. And then I encourage you to then ask them what they think is physically wrong. And sometimes you can get some interesting responses to that. My classic case would be the person who said, well, myofascial pain, doctor, that's great, but you know what I'm really worried about is I think I have cancer, a form of cancer. I have a cyst, and I think that's the reason that I'm here. That's what's explaining my pain. And that can be extremely insightful to know exactly what you think the patient thinks is going on. And typically, my dad died of cancer, and he had low back pain, and they thought it was just mechanical, but it turned out that he had a cyst, and he died. And so that's what I'm really worried about that I have. So you get into their kind of a mindset. You get into looking at what they think is physically wrong, which provides then perhaps a perfect opportunity to educate, challenge maybe some faulty beliefs medically that they hold, or just the possibility that that's something they're worried about. So I recommend starting there, and again, have the patient write what they think is wrong on this piece of paper. Again, it reinforces their involvement in their care, and they're not just sitting back letting you do something to them. Then I like moving over to the upper right-hand corner of this, because physical therapy, I think, is a huge benefit for people with persistent pain. Now, again, let me clarify that this is for people not with acute pain necessarily, but with chronic persistent pain problems. And I want to make that distinction. Nonetheless, over the years, I've kind of stumbled on some great quotes, and one of them is, I think, from Aristotle: "Movement is life." And I think pain scares people, and it tends to immobilize them, and they don't move. So getting a team member, a physical therapist, who will be able to help people kind of challenge themselves and address avoidance and start moving is going to be a huge component of their plan and of this map. So you want to look at how deconditioned they are. Is muscle weakness, has that developed? And then I like to ask the question about interference. I'll frequently say, Mrs. Smith, before this pain problem, you were this active. And sitting in front of me right now, I assume you're below that. Give me an estimate as to how much you think that is, how much of a drop that is. And then now they're starting to interact with you, and they say, oh, I think it feels like it's 80%. And so now you get an idea of how impactful they're perceiving this to be. So 80% of their day is they're not doing anything because of pain. You then tie into that question about avoidance. How much of all the activities that you had, how much do you feel you avoid? A lot, medium, or a minimal? So you get at that whole idea of how impactful the pain is in their life. And ideally, with the help of a team member, physical therapist, we can begin to teach pacing and modifying activities so that they can start engaging in life again to the best of their ability. Any questions on that? This is interactive time, hopefully.
I really, I have to say there's 2 points I want to make about this. Is one, I like the question in the middle, what do you think is physically wrong? And I see patients who come to me, and after examining them, to me, it's clear cut on what is causing their pain problem. And a lot of times when I kind of give them that diagnosis, to see them kind of look at me kind of odd, and then ask them, well, what do you think is going on? And what I find very interesting is a lot of times they'll have met some physician previously who told them something, and they've hung on to that diagnosis. And even though they've been treated for that and they didn't get better, they still believe that that's the problem. And I can't tell you how many times I've had a patient say, well, doc, I went to the emergency room and this physician did an MRI and they told me that I've got the worst spine that they've ever seen, and they're surprised I even am able to walk. Yeah. And I look at their MRI and it's pretty normal. It shows minimal degenerative changes. But this individual, because that physician planted that in their head, thinks that they have the worst case that's ever been seen. And so I would, I guess on the flip side, I'd encourage physicians to be careful about what language and what things you tell physicians or tell your patients, because your patients may cling to that and may prevent them from getting better. Second thing I like is there's a lot of times where, I'll go through a patient, tell them their diagnosis, and then I'll come up with a treatment plan and go through like 8 things. And I can see that while I'm talking to them, their eyes kind of cloud over, and I can tell that that's not what they expected or what they want to do. And a lot of times I'll stop and straight out ask them, how do you think I can help you? Or what's your expectation of what I can do for you? And it's interesting to hear what they'll say. A lot of times, I guess, being cynical, I'd expect, well, I thought you were going to give me more Percocet, or you're going to increase my pain medications. But there's times where patients don't even bring that up. They'll be like, well, I thought you would, I thought maybe going to see an acupuncturist or a massage therapist would help. Can you make that referral? Sure, I can make that referral. So I think it's interesting to ask them what they were expecting to get out from the visit, and what and straight out ask them, what can I do to make you better, or what do you want me to do for you? And a lot of times you may find that maybe I want you to increase my medications, but you may find that the patient has some other alternative way of dealing with the problem that you didn't even think of.
So you get them to start offering ideas. I like that notion, and asking them what they think would make a difference, rather than what could be done to them.
Correct.
What they think could make a difference. So then you end up hitting some gems, like physical therapy, massage, whatever.
It's interesting. I saw an 81-year-old woman yesterday, and we've been asking her to go to physical therapy for 3 months, and the husband, I think this is a codependent relationship, and it kind of gets back to that biopsychosocial model. The husband tells me physical therapy will make her worse. It's damaging her nerves, and you don't understand that, doctor. And I try to say, well, whoa, well, she's, it's not, can't damage her nerves. I said, if anything, it's normal that she's deconditioned, and for her to start doing physical therapy for her to hurt the first 4 to 6 sessions, and after that, hopefully she gets stronger, her pain will be less, and she'll be able to do more. It may not make her pain-free, but you may find that her functions improve. And, he looked at me like I was crazy, and I think he is instilling into his wife that she shouldn't be doing physical therapy. So it's a kind of a bad relationship in that sense. Instead of being supportive and trying to encourage her to do more, his solution, when I asked him, well, what would you want me to do? He goes, I just don't understand. She's 81. You should be giving her more Percocet. As she's on oxygen. And I'm thinking,
but the belief system may be that she's old and she's kind of coming to the end of her life. She can't be moving.
Correct.
So you kind of uncover some of the themes that maybe they're worried about.
Correct.
That's that caring person. When you're talking about that, and this goes right into pain is inevitable, but suffering is optional. And when that person makes that, you have the worst spine that I've ever seen, that gives them permission to be one, special, and then also they like that concrete thinking. It's like, this gives me a reason to be able not to do all of these things. And when you're doing a whole person evaluation and assessment and getting their feedback or buy-in, that might have been true but how long have they been working with the chronic pain?
Correct.
And how long are they going to be working with it? And what is the answer? So when you're looking at all of this, it's taking into account, it's very thorough. I really like that map. Running map.
Yeah, again, it maybe implies it's a team effort. You know, it's not the doctor's going to pull me through this, but I need to actively start looking at doing some things.
Well,
And here's a template of areas to look at. So the ultimate dream is to maybe have the patient circle the ones that they think are the key areas up there that they need to have addressed or looked at. So with that said, if I could, let me just scan to the next one below it, which is medications. And here's my take home on that in a nutshell. You know, if medication should lead to an improvement in quality of life and an improvement in function, your ability to do stuff. If it doesn't lead to that, then there may be questions as to how valuable it is. And I don't know what your experience has been, Dr. Patterson, but there may be some folks that, you know, they solely focus on it's about pain reduction. It's about curing, taking away my pain.
Correct.
Yeah.
So another new consult I had 2 days ago was an individual who, you know, probably doesn't realize that I can see their PMP report and see exactly what they're on, and looked like she's a work comp case that's seeing another pain physician, and must have complained about them reducing her medications and wanted to see a new pain management physician. So she comes in, and I immediately look. She's on Valium 3 times a day. She's on Ambien at bedtime. She's on Soma. And then on top of that, she's over probably about 150 morphine milligram equivalents a day. And so I walk in and I, you know, tell her, hey, you know, I don't want to waste your time, you know, and vice versa. Don't waste my time. But if I take over your care, the Valium's gone, the Soma's gone, and you know, we'll see what we can do about getting you off the Ambien.
Yeah. But
But at least the first two are automatically gone. The Soma immediately, and the Valium over the next 3 to 6 months. And then, you know, talking to her, I said, well, you know, why are you here? And I look at her report of pharmacy, and I can still see the other pain management provider just refilled her meds 10 days ago. And she said, well, ever since he cut down my medications, my quality of life and my ability to function have diminished. And I really look, and it looks like he only cut her back, you know, probably 30 pills on the short acting a month. And he did it about 9 months ago. And so she made it sound like it just happened just a week or two ago, you know, and when I went over it with her, I said, hey, I can see here this happened 9 months ago. Well, yeah, my life has been worse since then. And for me, you know, she's getting that through work comp. This isn't a transfer of care for work comp. And I let her know, well, look, even if you want me to take over your care, I probably can't.
Yeah.
You're under a workman's comp claim, you're seeing your other physician. I would probably need a letter from him asking me or telling me that he's no longer going to prescribe to you. I guess I could, under your private insurance, take over your prescribing, but you know, like, these are my conditions. She ended up leaving shortly thereafter without providing us with the baseline drug screen, which she was aware that if she did not, I would not take over her care ever. So kind of a fascinating story. I think she just thought that, hey, you know, this guy's being cruel, you know, you need to help me out. And I think, you know, in retrospect, what this guy was doing was just following the CDC guidelines. He was trying to get her, he was trying to wean her down to the 90 morphine milligram equivalents or less, and this patient was upset. Yeah.
So medication certainly is on the map, and I'd like to reinforce that it's only one of many components on the map, and hopefully, you know, just the visual picture of this shows that it's not the only thing that we do for pain management.
Correct.
You know, continuing through this loop here, make it kind of quick, and then hopefully get some questions. But you know, 8 out of 10 people, I think, 6 to 8 out of 10 people have sleep problems tied to chronic pain. And that can come just in the form of fatigue, daytime sleepiness, poor sleep hygiene, and possible obstructive sleep apnea or central apnea. My take-home message today for you is that, you know, oh my gosh, what can I do with that? Well, you can certainly send them to a sleep medicine consultant, but, you know, in that session, you could talk real quickly about sleep hygiene. You can plant 2 seeds, and say, hey, when you go to bed, do you see your clock? Are the numbers facing you? If so, turn the clock away so you're not then watching the clock all night. Simple little things like that may be enough to just offer a little change in that particular area, and it reinforces the notion that they can do something for themselves with sleep. Moving around the outside again, we talk about goals. It's very important to ask people, I think, what are your goals living with this pain? Typically, they're going to say, well, I want to go back to the way I was when I was 18. I just want to get rid of this. I don't want to have it. Please fix and cure me. And that's an opportunity to work on trying to take that and readjust and modify some of those goals, because that's pretty much all or nothing thinking in a lot of other problem areas. But what I found in my practice is the people that have done the most successful, if I really analyze it and distill it down, they were ones who were able to find something bigger in their life and shoot for that goal, whether it's occupational work or volunteer work. They found something better to do. And
Distraction.
And it's a form of distraction. It's a form of I'm bigger than my pain. And so the important message here is to get them to start looking at goals. How do they want to be different? And what do they think they can do to set and achieve those goals would be important. The very center, it's always fascinating to look at, to me, the circumstances of the pain and what role that may play in their current experience. Those people who've had pain start as an injustice, a fault, somebody's to blame. They didn't put salt on the ice and I slipped and fell at Sclary's, and Sclary's knew that they had a problem. That meaning plays a huge role in understanding this person's pain. And frequently to understand that can also maybe help you get an idea of some of the things they need to work on, which may absolutely have nothing to do with the L5S1 herniated disc. It may have everything to do with the anger and injustice they feel is going on. So, since take a look at that just to understand and perhaps help them get the help they need, looking at the meaning of their pain. Below that, I just put coping strategies with a plus and a minus. Get them to take a look at, are they engaged in more active, positive coping strategies, or are they involved in passive ones, the negative ones? Are they laying down with pain, taking a pill which tends to reduce activity and movement? And just get them thinking about positive versus, active versus passive coping strategies. Personality traits as we move around, fascinating. I think research shows there's no pain-prone personality, but there certainly are traits that can set the stage for problems when people have persistent pain. And the one that I've seen, huge themes, which is I'm out of control. I don't have control of my life anymore, and pain has taken it away. Explains a lot of folks with pain. Coupled with this theme of perfectionism. My favorite question is to ask someone, if I were in your house, could I eat off your floor? When they say yes, I go, okay, we've got somebody who tends to be perfectionistic, and you can see where this sets the stage. I can't relax until the whole house has been vacuumed. And now we go back to the upper right-hand corner. They're not pacing well because they'll vacuum the whole house and come collapsing down. Although they feel good because they got the house perfectly clean and you could eat off the floor.
Yeah.
But so you engage them in this conversation about, hey, how's your person, how do you see things and what role does that play in perhaps the maintenance of this pain problem? Well, doctor, I need to have zero pain and then I'll be done with your pain management. Not 30%, reduction to 30%, it's got to be all or nothing. Yeah. And that's a challenging person who's experiencing pain, which then moves me up to the next category, the beliefs in pain, and that black and white thinking, that all or nothing, and the catastrophizing that this is awful, this is terrible, I can't handle this. Those ideas, do they help the individual or could they possibly hurt and perpetuate? Just getting people to begin to look at that idea. And again, my thought is with this map, you redirect it to them. And you say, hey, circle these things that you think are important to you. And if they start circling these, then those would be areas to work on. Moving up the ladder again, we've got substance use, some pretty standard things there. The idea that smoking, a lot of folks I've seen have had fusions prior to coming to see me. And, we know the role of what cigarette smoking does to the fusion. If you could mention something on that, but it's not good.
Yeah, it doesn't allow healing. The microvessels of the spine, even for a person who's not fused, I mean, that's why a lot of them have degenerative disc disease, because those vessels are so small and smoking clamps them down or destroys them. That's why they have degenerative disc disease, before they should.
Moving up the ladder, everyone that I've seen that has a persistent pain problem needs to feel validated. They need to feel like they're being heard, and hopefully this is a process to do that with this map. But the whole issue also of past trauma, I think, is fascinating. They did a classic study in the 1990s, outlined in the Journal of Spine, and they looked at 5 risk factors and surgical outcome from low back surgery. The 5 risk factors were physical abuse, sexual abuse, and emotional abuse, parental abandonment and neglect, and parental substance abuse. And the findings were incredible. So if a person hit 5 out of those 5, there was like a 95% chance that the lumbar surgical outcome was poor. That they continued to have pain, they continued to need medications, and they continued to complain of pain. And almost the same statistic when you reversed it. If they had none of those early childhood risk factors, their outcome from a lumbar surgery was very good. So you have to scratch your head and say, well, what does a past history have to do? What is our history of trauma in our lives? Now, it may suggest that, the biological factors that are presenting in this patient may be important, but they may not be the most important thing that we need to address. Correct. And that as a team, maybe we need to involve other professionals in that regard.
So you're looking at ACEs?
The ACE data is fascinating. Yeah, what is it? Adverse childhood experiences? It parallels that perfectly. So, people come into your office with a history. It may be useful to have a quick idea of what some of that history may be and its role in this presenting persistent pain problem. Last but not least, the big 3, depression, anxiety, and anger, certainly a consequence of chronic pain, persistent pain, and definitely when addressed as a team, I think it enhances the positive outcome. So,
There's a question here.
thank you.
It's right on the screen there in front.
Oh, it's on the screen. Okay, let me read the question for everyone. May I ask you to talk about your experience working with other healthcare professionals, pharmacists, care managers, exercise physiologists, as part of the expanded team treating patients with chronic pain? Any insight about the use of PMP? It is useful when talking with patients about is it useful in talking with their patients about their treatment plans? The first part of that question, if I could address it, actually I have a slide. If you could, I'm going to take us down to this one here. This may help with some of the responses here. That in my profession, my recommendation in terms of inviting, if you have the opportunity to invite a pain management psychologist, try not to use the word psychologist, because that tends to put people off and suggest that the pain's not real, it's all in their head. I prefer the phrase behavioral medicine specialist. And the only reason I offer that word is just to allow that person to show up to my appointment, and then I can deal with what I do. But at least that gets them to my office. And I know Dr. Patterson's done a great job in integrating a number of different disciplines, and let him talk about that. But so use the phrase behavioral medicine specialist instead of psychologist, and re-emphasize the team approach and the coaching kind of a model that we use. If you comment on that.
Yeah, so I think working with those other people is very, very important. And I think choosing who is on that team is important as well. I mean, I've had situations where I had a patient who had a genetic disorder called Nell patella syndrome, very rare. And her belief is that she should be on more pain medications. And, I'm trying to talk to her that she's 30 and there is no cure for her condition. She's seen specialists even at Stanford who recommend against opiates, and I'm talking to her about that as well. Unfortunately, prior to seeing me, she'd seen another pain management physician that thought giving her Dilaudid was the answer. And so to me, Dilaudid is a very bad mechanism or a bad treatment option for a patient with chronic pain, and so I took that off the table. But as I was, weaning her off and trying to transition her to other medications, we kept having an abnormal drug screen. She must have had to supply a lot of it at home because her P&P didn't show that she was feeling more unless she had another source to get it through. But, I was trying to get her in with behavioral health. I was trying to get her in with physical therapy. I was trying to get that. Problem is her pharmacist, she kept calling and saying that the pharmacist was giving, telling her she needed like Opana, she needed this, she needed that. And he was sabotaging the rest of our work. So I think having a team you can trust, all giving the consistent message, you'll get a good outcome. You just got to be careful about who the patient chooses to be part of that team, because they could sabotage the rest of the work you guys are doing. So yes, I encourage you to get a team. I think a team effort is going to get you, if you're all giving a consistent message, would be great. You just got to be careful on who that patient wants to be a part of that team as well, if you don't know that.
Yeah.
Just for background, Lori's a pharmacist herself.
Oh, okay.
Oh, okay.
Yeah, so I found it interesting that this pharmacist was giving, medical advice to this patient, which was sabotaging my care or help for this patient, because they believed that they needed more pain medication because their pharmacist was encouraging to them. And at first I didn't believe that was the case, but I called the pharmacist and it was true.
Yeah.
The pharmacist and I got in an argument over the phone on, how to treat this patient.
And my experience with this team approach and pharmacy in particular in the 80s, I worked with Richard Cronin, who was UCLA's pain management director, and we had a pharmacist who would create a liquid pain cocktail for Dr. Cronin, where the patient didn't know what was in it. But indeed, over time, he was decreasing all of the meds. And so it's down to where, they had very little, and the patients loved it. They knew what was going on, but the pharmacist was a key team member at the time. So yeah, including not only pharmacy, but also all your field, alcohol and drug abuse counselors can be critical. And I think you may find more alcohol and drug abuse counselors in the rurals than pain psychologists.
Absolutely. That's why the trust factor in understanding where the team philosophy is, because every team is not made the same. When I work with someone, one of the great things is I have an hour with them, where a busy physician would have like 8 minutes with them. So when I get the person, we're working together to explain what that person is going to expect from the withdrawal. Recognizing that the healing process is not pain-free, that they're actually going to be feeling different things coming up. So we get the junk out of their system, and that takes a relatively short amount of time comparably. That's called detox. Then the real work begins, and it's hunting down the anger, the remorse, the guilt, the life that they've left behind, the life that they're projecting that they should have. They're shooting all over themselves. It's really working with them to go down to find out where the actual issue is, if there is an emotional or mental issue that needs to be addressed, and where that trauma is, and where those childhood experiences are, and where that person is. Then when we get down to that area, that's where I go to a different specialist, Dr. Lewandowski, to take them from there. And so my area is brief. However, it gets on the same page with, I try to keep it brief, but I try to get the person in, explain what's going on, explain physiologically, psychologically, environmentally, socially, all of the things that they can expect, and then kind of walk through them with the pain until we can get to the core issue, and then tee it over to the next part of the team member and bring it all back around.
Yeah, so consistent message from a team is great. I think that gets you a good outcome. The other thing I want to point out about a team effort is that it doesn't put all the onus on one individual. If one person is trying to do all the treatment, you're going to get taker fatigue, and you're going to probably if you're doing all the heavy lifting and you're the one trying to do all the work for the patient, you're going to wear yourself out, and eventually that relationship's probably going to end poorly.
Which is why we have the pain map.
Correct.
Put some of the weight back on the patient.
Correct.
Did that help answer your question?
The second part about the
Yeah,
PMP,
yeah.
let me put some input in that.
Yeah.
I think the PMP is excellent because when a patient comes in, you know exactly what they're on. And with the CDC guidelines being published now, you can look to see if they are on a benzo and you know what, or how much pain medication and how much of a benzo they're on, or other controlled substances. Two, you can see if they've been doctor shopping. You know, do they have multiple prescribers?
Mm-hmm.
And then the third thing that I see with the PMP is, for me, is it almost acts like a truth serum. That I already know the answers to the questions. I ask the patient questions about it, and I see how truthful they are. So a lot of times patients will come in and on their initial paperwork, they'll put that they're taking 12 Percocet a day, and I see that they just got filled only 60 in the last 30 days. Well, they obviously aren't taking 12 a day. They would have ran out within a few days. And so I find that fascinating that I'll ask questions based off of what I see in the PMP, and I'll see how truthful the patient is with me. And a lot of times I'm able to suss out who is, you know, addicted by, trying to get more pills out of me versus who's actually trying to get better and get pain relief.
I had a question, kind of a follow-up on the PMP, is do we now have the surrounding states of Nevada? Is our system reading into theirs yet?
I think when we log in, it gives you different states that you can click on. So I even had a patient come from Louisiana recently, and Louisiana was one of the options. And I clicked on it, and I could see exactly what the patient was filling in Louisiana, and what the Louisiana doctor was. There's still some states that don't participate. I think one of them is Oregon. I had a patient traveling to and from Oregon in between appointments, and I wanted to see if they're doing it in Oregon. Wasn't an option. I even tried to call Oregon, and they told me that I was violating the patient's privacy, which I found very fascinating, that they took that stance and told me that I shouldn't be calling and asking those types of questions.
How about California?
California is not part of that, but you can separately get on it. I think for some reason California is afraid that you are going to, if you click on that, you'd be looking up stars, Hollywood people, and so they want to keep California separate. So you actually have to go through the California system and actually have a notary done before they'll let you on. You just can't get online and register. There's a formal process in California.
Actually, I raised the question, do pharmacists have the same ability to get on?
Yes.
Okay,
they do.
Interesting. Thank you. And you said, it's not easy cookie cutter approach to treating patients with pain. And it's absolutely true. You need to customize it and tailor it to their unique needs. So
Keep the puzzle moving.
yeah,
Sure.
yeah. Well, thank you. Any other questions? Thoughts? With that said then, let me go back, if I could go back one. Here's the take-home points. So get the patient engaged, have them fill out the pain map, get them with a pencil and paper and clipboard. It's not a passive, this isn't a passive sport. This is a team sport, and it's an active one. And, basically, it's your voice, your pain. You need to be heard. Hurt doesn't mean harm. That's a common, I think, misconception of a lot of people. I don't want to fall into the avoidance. I don't want to do anything that's going to harm me. Well, starting to move and start physical therapy is going to hurt, and you're going to be sore, but that's okay. Yeah. We talked about movement as life, and like Paul had said earlier, people who have better things to do suffer less. So good luck with your patients, and hopefully you'll take a point or two out of this today. Thank you.